Thank you, Allison. That was great. Good afternoon or good morning, depending on where you're situated in the United States. My name is Mary Lou Smith. I'm co-founder of the Research Advocacy Network, and I'm going to expand on a couple of topics already discussed by John and Allison. I will also share some resources at the end. So women and men with metastatic breast cancer have difficult treatment decisions to make. There are some overarching questions. Do you try a trial as your first-line treatment or go with existing single agents? The trial will offer a new approach and the hope of better response, but the established treatment side effects and efficacy are known. If you wait, will you then be ineligible because many of the clinical trials are in first-line therapy? Do you take the most aggressive treatments in the hope of a longer response, or will the side effects limit your quality of life and future options? Is it better to be treated at a university hospital where research is ongoing, or better to stay closer to home where you have a support system and less life disruption? And looking at the long view, how are you going to be able to live your life with ongoing treatments? So how are treatment decisions made? By the doctor, by the patient, or by both? These statements were made by patients with metastatic breast cancer responding to a survey the Research Advocacy Network conducted in 2018. The responses reflect the three models of decision-making. The paternalistic model, where the physician decides the treatment. I go with my oncologist's decision. Or the informed model, where the patient makes the decision. I'm the driver of my treatments. We discuss options, but I make the final decision about everything. Or the shared decision-making model, where the patients and providers make the decision together. I like that I am fully involved in my treatment decisions. And some, unfortunately, patients felt unheard and devalued. My suggestions were acknowledged and then ignored. The shared decision-making model is preferred by most patients. In a shared model, the patient and physician partner to look at the treatment options and come to a mutual decision on the best treatment given the effectiveness of the treatment, the physical side effects, and the patient's preferences and values. Trust is foundational to this model. Patients and physicians prioritize benefits and side effects differently. Two patients may not weigh the risks and benefits the same. Patient preferences are truly unique to the individual. 40% of patients reported they did not have the desired involvement in their treatment decisions they would have liked. The Research Advocacy Network was a partner in the IU Department of Defense Breast Cancer Center of Excellence. As part of our work for the grant, we wanted to find out how metastatic breast cancer patients viewed the trade-off between side effects and benefits of their treatments. With the help of the Metastatic Breast Cancer Network, the BC Mets listserv, and Living Beyond Breast Cancer, we were able to offer a survey to over 1,200 patients. Over 600 responded to the survey, and we published the results. We found benefit mattered more. Toxicity was more determinative if the person had experienced that side effect before. And some patients would take treatments in all the 20 scenarios we put forth. We learned a great deal from these patients. Here are what the patients said. We support each other as we live with uncertainty, pain, and most of all, hope. We value quality of life. We live with side effects, some of long duration and some end with treatment. We're confused by the information we receive about treatments, and we question the choices we are offered because of the lack of evidence of individual benefit. We're looking for clinical trials, unlike other patients who must be sold a trial. We have a stake in cancer research. Some of us are betting our lives on it. A recent study of shared decision-making found patients and oncologists thought effectiveness of treatments and types and severity of side effects were important to decision making. Patients went beyond benefit and side effects. They factored in cost, travel time, work, children living at home, and the ability to attend important life events, such as graduations and weddings or the birth of a grandchild. Patient preferences reflected a wide range of concerns about how treatment impacts life. All side effects are not created equal. Fatigue that means I need to take a nap is not the same as fatigue that means I cannot work. Peripheral neuropathy that causes a mild tingling in my fingers is not the same as peripheral neuropathy that causes numbness and pain so severe I can no longer button my shirt or safely pick up a glass of water with one hand. A shared understanding strengthens the patient-oncologist alliance, builds that needed trust relationship, and creates a framework for future decisions and ways to support the patient and their family. Physicians do what they are trained to do, rely on the evidence. What is known from the research about effectiveness of treatments and the side effects of those drugs? They acknowledge they cannot predict a particular individual's side effects or benefits. They use statistical estimates in making their recommendations. Some physicians make assumptions about what patients would prefer. Patients want to be asked, and asked more than once, because their preferences may change over time. The caregiver could initiate a discussion about patient preferences each time a change in treatment is needed. That would take the burden off of the patient and still ensure their voice is heard.